with the valve first, and then after decide about the cracking.
Rogerio, I think there was an interesting discussion because Didier was suggesting a 23 or a 26. We were discussing more a 26 or a 29, because the experience with this bioprosthesis is that it's really fracturable and it will really open up, and the native anatomy is quite large, right? So Adam made a comment that during surgery more than a decade ago, the surgeon really constrained at the annular level, because in the LVOT was 27 millimeters. So we feel, or the idea even was to consider a 29 millimeter, and if we would have gone for a 29, we would have started with fracturing.
Yeah,
that was basically the suggestion,
and
right?
I think the decision here is to go with 26, also because of the age of the patient. If we had a younger patient here, I would think I would be more in favor of a 29. But here, safety and age and all this together, we decided to go with the 26. And you see the anatomy on the screen. You have you can appreciate that the anatomy is large, and the valve is very small as compared to the size of the sinus.
And the guys did a fracture case yesterday, and
Fabio, it's not so easy to crack in the Braille one.
Yeah, the Braille valve is a fracturable valve, but at very high pressures. We normally go up to 24, 25 atmospheres with the Atlas Gold balloon, that is the non-compliant balloon that we have available in Brazil. But it's high pressure. It's different than other valves that fracture with much less pressure. So we're going to be very high here to fracture this one.
But the incremental benefit in terms of sizing is huge, right? It's not a millimeter.
It's huge.
Adam suggested 4 or 5 millimeters, right?
Yeah, it looks like you can gain a lot. So we feel comfortable with a 26, and then fracture to let it open more. A 29 would be incredibly constrained if you put it in first, maybe at risk of an infold or something. So then you would fracture first and put the valve in. But he might get, if you fracture this valve first, he might get sick given the amount of AI he has to start. So we felt the best overall strategy was go middle of the road with a 26, put it in about 4 millimeters deep or so that we have enough valve underneath to safely fracture after.
And then, Adam, what you said in terms of risk for coronary obstruction, the sinuses were in a different time zone, right?
Yeah,
that's what you said, right?
Coronaries are in a different time zone. So no risk of coronary obstruction. The SDJ is plenty wide here. So
I'm going to keep that one. That's so cool.
And I also want to hear a word from you guys, because we have the FX here in Brazil very recently. So you see that there are 3 markers at the bottom of the valve, at 3 millimeters to the tip of the valve. So any advantage of using these markers to position the valve, to have commissure alignment? What is your experience, Nick?
I think it helps a lot with the interpretation of your depth of implantation and also with the commissural alignment. So it is definitely a significant step forward in terms of commissural alignment and achieving reliable implant depths. Yes. And so what you also see here, so we keep the markers now in sight. Is this more or less a coplanar view, or is this
probably close to a non-cusp isolation? I mean, we're
and this
cusp overlap.
And this is what you want to see. So the 2 dots on the left side of the screen,
and our ring, is also nice and flat.
That would give us commissure alignment, right?
Exactly.
And that's, you comment before, it might be related also to hemodynamics and durability. We still have to be proven, but...
And we're not going to aim too high, so we are aiming for 3 to 5 millimeters, and we know that the dots are at 3 millimeters.
You want to have them here.
Yeah, the depth is really important here, because the next step is going to be to fracture.
So if you are too high, there is a high likelihood of embolization of the device. So it's setting a proper depth initially makes sense.
What's your target zone, Didier? 3 millimeters?
Yeah, I guess 3 is very, it's a nice target. And for the audience, it's very important. You see the belly shape of that device, and definitely the likelihood of embolization is high. So you have to integrate that when you go for post-dilatation. So that's exactly what I was saying. At 26, in such a small anatomy, it's going to be extremely difficult to stabilize. So potentially going a little bit deeper is going to be helpful, but if you go deeper, you're going to lose the supraannular, some of the supraannular aspect of the device. That's why the size selection is very important. 26 is probably appropriate for the patient, but it's going to be technically extremely challenging to come.
And do you think, in thesis, if we crack before, it's going to be easier to do the, yeah. So that's why, in my personal use, I prefer to crack before.
When he comes off the patient this time, maybe walk it down slowly. Yeah. Or we'll start again here, maybe a little bit lower.
Are you pacing?
Not too low.
This
Not yet.
cracking before or after. Santiago Garcia has published some
Better to
data
do after,
showing
right?
that it's better, safer to do after. That's why but of course, we might need to change the strategy here depending on what we get during the procedure.
And then have him walk the patient down slowly.
Now for me it's much better. Without the belly shape,
Agora vai diminuindo o marca-passo.
empurra um pouquinho para frente.
Henrique, which speed are you, the rate? 140?
160.
160?
Yeah.
You know, there's
120.
the LVOT is so wide in this
120.
case at 27. There's very little risk of
100.
you know, heart block here. We know we're going to fracture this valve, so we're trying to little forward.
Pode desligar.
Yeah, don't push too much now, because looks like it's slipping down. You also know there's no calcium on these leaflets. It's pure AI from a broken leaflet. So you know you could, you know, this valve might want to tend to go down.
Do you think we could see the hemodynamics, the aortic pressure of the patient?
It's a little low.
It's very low right now.
Do you want
So
to
we are-
deploy, or you want to?
Because sometimes you see with these externally mounted bioprosthesis, you need to bring the marker band really close to the paddle pockets, because the leaflets of the failed bioprosthesis are quite long. So if you go closer, you're going to get a better aortic pressure. So sometimes,
Marca-passo.
You ready to pace?
Pace, liga o marca-passo. Very slowly, very slowly.
So we're going to leave that
Frequência de 100.
the depth in the LV for be pacing here. Can you go fast? Not pace faster. or you
120, 140, 140 agora.
Now it's very important to release the tension of the system. That's perfectly demonstrated here.
Pode parar o
want to
marca-passo.
walk down the pacer?
Pode tirar o marca-passo.
Oh, hold on. Make
But you can see the valve is clearly constricted. Yeah, you need to grow.
And you have the impression that it's deep, but make no mistake. When we're going to balloon this will give the impression that it will foreshorten a little bit. So I think I'm happy with this depth.
Yes, I like the position, yes. Of course, ideally, if you could put it a little bit higher.
No, I would not do
But
this.
then it can pop up.
Yes.
So you
Yes.
have to pay.
And we're going to do an aggressive fracturing now. So we're going to use the balloon we're going to use is a 22.
22, and remember, the internal diameter was 15, 16.
Yeah.
So we are aggressive.
Yeah. No, I like this depth. Didier, would you have implanted higher?
no, I think strategy-wise, that was what we were discussing here, potentially do the fracturing before. Then you get a bigger ring and a bigger landing zone, and then it's going to be easier to deploy the Evolute FX. And potentially, if there is a need, you can do a gentle post-heal to reshape everything. But moving higher, to answer your question, Nick, no, because the risk of embolization would have been too high for this patient.
So I have no experience with fracturing before. Would it create more instability for the valve itself, for the positioning? So would you have a higher likelihood of pop-outs or migrations when you fracture up front versus fracturing after?
I think you have, I bet you, in my experience, you have a higher chance of
Diving,
ventricular diving
Yes.
in because now you have nothing to
hold it.
Yeah.
Yeah.
So
I
you
think-
have to rapidly pace 180, 200 and then until you get full expansion. At least that's my
And
thought.
remember that the Atlas Gold balloon takes a long time to deflate. So we're gonna have
Release. Let go.
a long rapid pacing
go.
here.
Let go. Yes.
And this is one reason why
you go.
sometimes the patient
And then you hold.
gets unstable.
Maybe there are some people here in the audience who are not that familiar with the valve fracturing. So if you could just describe the scaffolding, the way you organize everything, it could be beneficial.
Pressure is really high, so I'm waiting.
Yeah, I would wait until
So-
anesthesia
so-
lower the pressure. The diastolic, you
Yes,
know,
I'm
it really
about to
came up.
think
Can you see the hemodynamics? Obviously, the valve's working, and you know,
Yeah, we
now
can
it's
we can show we can see here. Can you put it on the screen the hemodynamics, please? Perfect.
he likes having an aortic valve. Right?
Yeah.
So we'll probably wait here a minute to let the pressure settle down, but we're seeing the diastolic over 100 now, and
The AR has been taken care of, so that's
So in
good.
the meanwhile, I think let's show the what we prepared here for the fracture. Oh, okay. So we have here, we will inflate with this syringe until the 22 balloon touches the valve. Then we go high pressure here with this indeflator here up to 20, normally up to 24, 25 atmospheres. When the valve breaks, it's very clear when it breaks because it gains a lot of space. So you're gonna see that.
there's apparently one, even though it looks like it's a complete ring, there's one solder point for the ring to be complete, and it's going to break at that solder point. Will open up like a clamshell. So we're gonna some work on getting the pressure down here a little bit.
Fabio,
How
another
much
thing
pressure
that
is he on here?
Another thing that we have changed from balloon fracture is that we already start with the indeflator with like 20 atmospheres to start. So when we turn the valve,
We don't lose time.
we don't lose time.
And
you
we
know.
should expect, again, this balloon takes a long time to deflate. So it's, you're gonna see that might get some instability.
Just a variation in terms of scaffolding. More and more teams utilize these two indeflation devices. This way you can keep them in an aspiration, and then while you rotate the freeway stopcock, it just aspirates and deflates easier.
Yeah.
You know.
Okay, we follow you guys. It would be extremely important to see the hemodynamics, to see the blood pressure. So if the team could keep you on screen at the same time the blood pressure, perfect. We need
So
the
while they're
TE probe.
Marcelo, sem eco, por favor.
Sure. I don't know if you can see the TE probe for now, but certainly the AI is much less. And if you want to make sure that they can see hemodynamics and fluoroscopy, that'd be great.
There you go.
So remember, 22 balloon, which is, you know, one more than the labeled diameter, but certainly 5 more than the true, you know, well, 6 more than the true inner diameter. So you'll see a nice waist on this ring that will pop. Should be pretty visible for you.
But within the dimensions of the LVOT, that's
Correct.
also important.
I think the most important lesson is it's not about the room in the sinuses. Everybody has room in the sinuses. It's about you have room in the LVOT.
There we go.
So there's your waist. Now there they're going to go. Boom.
Boom.
There it is.
Fractured.
Yeah. Stop the pacing.
Stop.
Here's the
Pode parar o marca-passo.
the long deflate on the Atlas Gold. But I tell you, if you really have to go high pressure, this is the balloon to use because less likely to rupture than a true balloon. The price you pay is just a longer deflate time. If you look now, some of those markers on the valve that are 3 millimeters deep have come a little closer to the cage, right?
So the space we gained there is
So
incredible.
we're going to
isn't it?
intentionally come off of the line of coaptation. Do you see the gap in the ring now? You guys see it?
Yes.
Crack.
Henrique, how much pressure to rupture this valve?
Right.
It was in between 18 and 20.
And look how that valve.
Right now
that
we
valve
went
is nicely
18
open
and it
now.
ruptured with 18.
So the shape is completely different.
Oh, yeah.
It was constricted and now it's fully open. So it's,
Pigtail.
and this patient had a surgical valve 12 years ago that was internal diameter of 15, 16. And now he gets a 26 fully expanded. So
He won't know what's happened to him.
He's going to run a marathon.
Can you see the echo images, Fábio? Ask Marcelo.
And I'm also curious to see the gradients. I'm expecting very low gradients.
Yeah, I mean, any of that gradient that we saw at the beginning had to all just be flow
Mismatch,
related, right?
yeah.
There was no stenosis there.
mismatch and flow. Diminui o zoom.
But the depth looks good. The valve looks like almost what it looks like out of the package.
Yeah.
Yeah, that's beautiful. And look at the AI index now.
Yeah.
It's impressive.
Look at the gradient. Jeez.
So
Eight.
show the gradient and the echo, please, both on the screen.
It's not every day that you see such a huge fracture. Huh? That's
No,
quite
that's-
impressive.
But Nicholas, one thing that's important in this particular patient of the anatomy, I don't know if Didier and the panel agrees with me, because you have a very large sinus of Valsalva. So it makes a lot of room for us to work on it and make the valve bigger and bigger.
So Marcelo, can you show us the echo, what you see there?
The positions quite well. I think that the opening of the valve is fantastic. The gradient is okay. The median gradient was almost like 8. The peak was 19 millimeters mercury, and I don't see any leak for a valvular leak. So mean was 8,
Okay.
and the peak was 19.
So you see
That's
here
fantastic.
What is his VTI though? He's high flow.
You mean the VTI? Just a second.
Because your hemodynamic gradient is 0.
Yeah. But even 8 mean gradient
Great.
for an
a
84-year-old valve in valve. It's
And
excellent
also,
hemodynamics,
take a look
right?
at the peak of the flow. It's early, so it's absolutely great.
Yeah.
It's not even medium or late, it's just early, so it's great. No doubt about it.
He's high flow, his stroke volume's high. But he and think about this. I mean, you would have put any valve inside, but you could see what the appearance was before we fractured, right? I mean, that was a very constrained valve, a balloon expandable. You'd be looking at a 20 wouldn't even open. Right?
So can you put a large image on the screen of the cine for us to show the valve fractured? Cuidado aí, Marcelo. Escopia.
There. Oh.
Yeah.
Yeah, take a picture.
Look at the distance of the ring.
Incredible.
So it's a lot of space there. lot of space.
It's impressive, the gain.
So let me ask you something. We are talking now about the shape of the valve, optimization of implantation. Didier, if you saw, for instance, this kind of hemodynamics, very low residual gradient, but still constriction, would you go ahead with post-pulse dilatation or do you leave it alone?
Yeah, that's a very important concern and issue that we have to face. And I would say that I would go for a positive because circularity, these devices are meant to be circular. The appropriate function is circularity, and we know that thrombus may be an issue if there is enfolding, if there is under-expansion. And so I would work hard to get a proper circularity that could be a guarantee or a surrogate for a better durability in the future.
And talking about thrombus, what's going to be our regimen for anticoagulation of these patients? DAP, single antiplatelet therapy, or DOACs?
Maybe we can ask the panel, because I'm sure everyone...
Rogério, start with you. Single aspirin only, aspirin plus clopidogrel, or DOACs?
Dupla antiagregação.
Marcelo, só puxa pouquinho para a gente fazer a imagem. So we'll do the final angio here.
I think double.
With this kind of result, aspirin alone.
Cressa.
Maybe DAP.
Aspirin alone, because large sinuses, and there is no data in the literature that promotes a dual antiplatelet therapy. The only thing to discuss is oral anticoagulation. So if the sinuses were smaller, with a lot of metal, a very low residual, smaller residual sinuses, I would have put the patient under
do not ignore the patient. This 84 by itself, it's a high risk for bleeding.
But okay, I fully agree. With a self-expandable valve, with a result like this, I probably go single antiplatelet therapy. But if you use a balloon expandable valve, you think differently? Because of in thesis, the chance for halt is bigger with a balloon expandable?
Any thoughts on that, Fabio, the team there? The anticoagulant treatment for this patient.
What about a CT scan 3 months later for us to make a final decision? Does it make sense?
I would say yes.
Because the risk of halt? Even with this valve very well expanded?
Yeah. For me, though, there's also a difference between if you go intraannular or superannular. These leaflets are so high up there in the flow. I'm with Didier. I mean, I'm not sure this patient needs anything more than aspirin.
But would you systematically do a CT follow-up? No. Me neither.
Me neither.
But if I had put a 20 sapien in here and fractured it with inside, then I might go all anticoagulation.
You know, the point of halt is that it's unpredictable. It comes and goes. We don't know. We still don't know what the clinical impact is. We speculate. I would have a closer echo follow-up. So I would definitely bring the patient back at 1 month for an additional echo, and then take it from there. But if at 1 month the gradient is still in the low numbers, single antiplatelet therapy.
Yeah, I agree. In our practice, I keep more strict echo follow-ups, and I only order a CT if I have a rise in the gradients. Otherwise, I will keep only on echo.
Yeah, in the vast majority of patients, yes. But if there is any concern in terms of the result, if perhaps it's use an annular, I think it might help. But again, echo is the parameter. We're not going to inject contrast in an elderly patient without having, a signal from echo that we should. So I agree.
Maybe we can ask the audience. So the question for you guys is, how do we follow up this patient? Who would go for echo alone? Raise your hand. So the vast majority. Who would add on top of the echo a systematic CT scan? So very few. So the audience is really sticking to your strategy here.
Yeah. Soft. You agree?
So how do you close the groin here? Is it a double pro-style?
Yeah, so it's a 2-pro glide standard because the access was really good. So yeah.
So Adam, maybe how much time do we still have, Rogério?
7 minutes.
Oh, 7 minutes. Maybe in 7 minutes we can show the case we did yesterday, because we had 2 cases selected, 2 valve-in-valve cases selected, and the one we did yesterday was the same surgical valve, but a much smaller anatomy. So we had to do basilica and then fracture the valve. So to show here the crossing, traversing with the wire. Maybe Adam can describe this much better than me, of course.
Sure. So there was the VTC was 0, the VTSDJ was 0 on the left. We thought that needed no room for a snorkel stent because of those 2 measurements. So we thought that leaflet needed to be modified. The right coronary did have a VTC that was a little bit better and a VTSDJ a little bit better. So we thought a snorkel stent would not get crushed. So we decided to protect the right and basilica the left. So that's an AL guide, pointed to the leaflet. Remember, these are externally mounted leaflets. Fabio expertly traversed right inside the sewing ring, snared it, it created the flying V, and lacerated the left. Patient also had AI to start. That seems to be the mode of failure of this valve in the rare cases when it fails. So here's the, to get a little bit extra splay, given such low numbers, this was a balloon-assisted basilica, so just a 4 or 5 millimeter balloon to widen the base, and then on the right you'll see the basilica. That's the nice slow pull, electricity, nice clean cut, and then the valve goes in. Similarly, there was an issue here. Remember, the skirt on the Evolute is 13. With a VTC of 0, you would still have skirt obstruction. This left main was only 5 high. So we intentionally wanted the valve 8 millimeters deep on the left, which we were able to accomplish. The valve's going to get deployed and released here.
Next slide.
And then if you go to the next slide, we always check to make sure that there's flow and there's room to do the crack. Very different patient. This patient's LVOT diameter was 21. So not nearly as much room in the LVOT. So this was a 20 millimeter balloon to fracture. You'll see the same waist that you saw today and the pop of the fracture. Patient got a great hemodynamics after that case, again with a very small inner diameter. But watch on the right again, you'll see the waist give and it pop pretty impressively. And then on the next slide, you'll see final pictures to show good coronary flow in both. So patient yesterday also got a great result. Similar case, but in terms of valve and approach, but very, very different anatomy.
And much higher risk of coronary obstruction, of course. So Rogério, I think we had a great case. I thank you all for helping us in the discussion here, DDA and all colleagues. So I think with that, I think we can finish the case, yes. Right? And the word is yours again, Rogério.
Fabio, Henrique, Nick, Adam, congratulations. Very well demonstrated, nice presentation. In fact, you have a combo of 2 cases presented in 45 minutes with awesome results. And I think that the patients will have a lot of benefit of this both techniques. And as we talked before, we're going to see more and more valve procedures. So you have to be skilled to do this kind of procedures with different anatomies, all challenge that it brings to us. Thanks a lot and congratulations.
Thank you. Have a great meeting. Thank you.
I don't know, before I call my good friend Didier to present the lecture, any additional comment from the panel?
No, I think this was beautiful. I enjoyed the second case as well that was performed yesterday, because this patient would have no option, refuse for surgery, and if we try to do something without coronary protection, basilica, probably he would have had a major complication. Thank you so much.
Perfect. So to close the section, I will call Didier again, and he's going to present us. I think that this lecture will be very nice to illustrate all we have been discussing this whole morning. So will better hemodynamics with self-expandable valve impact the clinical outcomes and TAVR durability? That's a very important question.
So that's a very tough question, and it's, I'm sure that you have your own opinion here, guys. So feel free, just a lecture for discussion, to open up the discussion, and if you have anything that you want to bring into it, please feel free to do so. There are a couple of elements, a lot of elements that, to my opinion, favor the idea that better hemodynamics are going to translate into better durability. The first, the most, I would say one of the most robust piece of data that we have had from the literature is the SMART trial. The SMART trial that compared self-expanding platform to a balloon expandable platform in small anatomies. Most of the population was a female population, and the cutoff was less than 430 millimeters square with a good balance. The 2 years data were presented last week at the ACC, and so this is really fresh data that you have. There were two components, two primary endpoints, co-primary endpoints. The first one was a clinical endpoint, and that tried to address the question of that lecture, the idea of whether or not there is a superiority in terms of clinical impact. At 2 years, what we can see from the SMART trial in this small anatomy population, small annulus population, there is no difference in terms of death, stroke, or rehospitalization between the self-expanding supraannular platform and a balloon expandable platform. So this is quite reassuring. Potentially, we need to wait a little bit longer. SMART is scheduled to obtain a follow-up at 5 years, so we're going to see more and more elements in the future. What we also know and confirm from SMART is that there is a clear advantage. There seems to be a clear advantage of a self-expanding supraannular platform in terms of hemodynamics as compared to an intraannular balloon expandable platform. And you can see the huge magnitude in terms of difference that favors the hemodynamics in the self-expanding platform group, once again in this small anatomy group. And whether it be a gradient above 20, patient prosthesis mismatch, the DVI, everything is in favor of the self-expanding platform. And this is something that confirms what we have had from retrospective collaborative registries. In terms of EOAs, you've seen this fantastic case. We started with very small anatomy, and with a mature technique, we can obtain large EOAs, and in the SMART trial, close to 2 centimeters square in this, once again, small anatomy population with a small self-expanding platform, and a very low gradient, single digit, 8 millimeters of mercury on average at 2 years, and this is really reassuring for our population. So one of the discussion was, yeah, but the definition that was used in SMART is kind of biased. So what we did was to try to compare any available definition of bioprosthetic valve dysfunction. And whatever the definition you use, it's exactly the same outcome that you observe, superiority of the self-expanding platforms as compared to the balloon expandable platform in smaller anatomy. So better hemodynamics and lower patient prosthesis mismatch. And what we know from the surgical literature, and now we have a follow-up that extends up to 10 years in this set of data, and you can clearly see that there is an impact, there seems to be an impact on mortality in the surgical literature. So if we translate that to the transcatheter field, to my opinion, there is no reason that we don't see anything if we wait up to 10 years follow-up. We should see an advantage in terms of mortality for a better hemodynamics. So that's something that is also interesting. This was a large echo database, the Australian database, and clearly it seems that when you have a mean gradient after the procedure, whether it be a TAVI or a surgery that is greater than 22.5 millimeters of mercury, you have a higher mortality, and that's something that we need to integrate. And I liked the way they worked during the life case to achieve a gradient as low as possible, because it seems that it is the way to go in the future. In contemporary practice, we need to be excellent. In terms of mortality, whether it be moderate or severe PPM that impacts mortality, From the STS-TVT database, what we can say is that it seems that it's only severe patient-prosthesis mismatch that impacts the survival of the patient. But what is very important, if you watch the right part of the slide, we can see in that meta-analysis that confirms that severe patient-prosthesis mismatch seems to impact survival. The curves diverge around 3-4 years. So telling us that potentially for the SMART trial, we need to wait till the very end of the follow-up of the patient to see if there is a clear difference in terms of survival. What we also know, apart from the mortality, is that if you take a younger patient and you put a device that is too small, you get a patient prosthesis mismatch, the quality of life is going to be impacted. So more dyspnea, less exertion capacity, and if we even, you watch the bottom left part of the slide, if we relate the severe patient prosthesis mismatch to the durability of the surgical valve, it has an impact, and there is an increase in the structural valve deterioration of this surgical valve. So to my opinion, there is no reason that we should not see the same pattern with transcatheter valves. SMART was almost a 90% female population, and it seems when we take the balloon expandable platform, based on this data from the partner free trial, that in women with severe patient prosthesis mismatch, there is an impact on mortality. So once again, mortality, potentially durability in the future. These are very important outcomes that we need to address. There is something that we discussed during the live case, and it's very important to my opinion, is thrombus formation. In the SMART trial, what we saw was that subclinical leaflet thrombosis was more important in the balloon expandable platform arm as compared to the self-expanding. The difference in terms of clinical thrombosis was exactly the same. But it seems that there are more thrombotic events in the balloon expandable arm. And we know that thrombosis is part of the definition of bioprosthetic valve dysfunction. So this is something that we need to address. And based on some data, it seems that if you have thrombus, whether it be extrinsic or intrinsic thrombus, this will lead to a higher rate of calcification. Calcification could impact deflate mobility and generate deterioration. So I do believe that addressing thrombus, preventing thrombus, identifying thrombus, treating that thrombus may be a way to promote a better durability of this platform. For the time being, it seems that there is more leaflet thrombosis issue with the balloon expandable platform. So, very important point. But not everything is negative. There are some positive aspects, and some data suggest that potentially that difference, hemodynamic difference, is not going to translate into a mortality. And this was an abstract that was presented at London Valve, and it's a 5 years follow-up of the partner free trial. And what we can see is that when you compare it was 100% balloon expandable platform, but when we compare a small versus a larger annuli, there is no difference in terms of survival, stroke, rehospitalization. So at 5 years in that population, there is no difference. But the caveat is that it's only about balloon expandable valve. There is no comparison with the self-expanding platform. And something at last that is debatable is the difference that we see, discordance that we see between hemodynamic invasive measurements of the gradients and echo gradients, and potentially that's something that we can discuss. We still don't understand how to address that, how we're going to follow up these patients, but clearly before the procedure and after the procedure, there is a huge discrepancy between invasive and the echo assessment. So how are we going to move in the future? It's still a matter of debate. And the main determinant for that is that concept of pressure loss recovery that seems to be greater with the balloon expandable platform. So you see the self-expanding platform on the right part of the slide, the balloon expandable platform on the left part of the slide, and clearly between the blue and the yellow and red, there is a greater difference between the echo assessment and the hemodynamic assessment in the balloon expandable arm. So to conclude, I would say that, to my opinion, valve performance matters per TAVI and favors a self-expanding platform, particularly the self-expanding supraannular platforms. A small aortic annulus is a population that is at particular risk of severe patient prosthesis mismatch, particularly the female population. So there is a potential to redefine the definitions of structural valve deterioration and the way we assess the gradients, hemodynamics versus echo, how are we going to integrate that into clinical practice? Still a matter of an open question. And a longer-term follow-up is definitely required to clearly answer that question about the potential impact on survival and durability. Thank you for your attention.
Great, Didier. Awesome presentation. I think that illustrates the landscape that you have ahead of us. And we have 5 more minutes to close the session. I don't know, any questions for the audience or questions from the panel? Alex, any questions to?
I think this is a fantastic and very hot topic because we see all this mechanism, but clinically we don't have strong data yet. So my vision, Didier, is that we're going to be selecting the different valves for different anatomies. So I think that this is going to be, I think, the key message before you have very solid data. You agree?
Yeah, exactly. I think it's today what we are still doing is treating older elderly patients. So the life expectancy, if you take a 80 years old, even lower risk patient, the life expectancy is somewhere between 6 and 8 years. So within this time frame, but it's likely that we're not going to see a difference in terms of durability or survival. So we could implant whatever device we want. So to my opinion, the lower is going to be the age of the patient. The more important is going to be to address several issues, integrating hemodynamics as part of the coronary issue pacemaker. But I do believe that hemodynamics matters potentially for predominantly for younger and lower risk patients.
So probably the future we're going to see the combination of hemodynamics, shape, as we've been discussing, as circular, the better the outcome, in my opinion. And also, in the near future, we hope that we're going to have different materials, biological materials that can last a little bit longer and be less prone to thrombus. So hopefully with this 3 combination, we're going to have a bright future.
So let me ask you one thing. Let's say we have had the Notion trial. Notion trial was had a 10 years follow-up showing that if you compare surgery to the core valve, a former device, at 10 years, even though the population, the population of patients that's still alive is small, there is no difference between TAVI and surgery. So the question for you is, what do you expect in terms of durability for TAVI in general? Do you think that it's going to be 5 years? Raise your hand. 5 years of durability? Yeah, I'm more optimistic. 10 years? Oh, yeah. So it's, I think we have the answer. And this is something potentially directed to the industry. What we want as a community, as implanters, as heart teams, is to have TAVI devices that last at least 10 years. This way we can treat our patients and we can keep options open. Because we're going to treat more younger and younger patients, and we need that degree of durability.
Perfect. So, thank you so much. And vamos ter um intervalo agora, retornamos às 10h30.
event.